Happy to be here, everyone. I'm Matt Maurer, founder at Stroll, and just thrilled to be here at Hero City today. It's been kind of a dream. So let me tell you a little bit about this. Stroll is a price transparency tool for patients in the American healthcare system. So I'm going to start off with a bit of a story to kind of help give you an in here. So a while back, I hurt my knee playing hockey, and I was new to the Bay Area, so I didn't know anybody. So I went to Yelp and looked up a knee doctor, and she told me, yeah, this is a pretty standard case. I think we'll get you an MRI, and then probably go in there and scope it out, which kind of means you cut in, clean some stuff out, send me on my way. I'm thinking, okay, it sounds routine. But I'm fresh off my parents' health insurance, and I have this cut rate plan, so how much is that going to cost me? And she said, well, I can't really answer that. Maybe someone in billing can help you get an idea. So I went to billing department. I said, how much might this cost me to do? And they said, well, we don't really have that information. Call your insurance company. They should be able to help you. So I called my insurance company, and I said, this is the situation. Can you give me an idea how much this would cost? I feel like I have a lot of skin in the game here. And she said, well, yep, you just have to talk to your doctor. So I was very confused, didn't really know where to turn. So fortunately, I called my older sister who runs a physical therapy clinic in Kentucky, and I said, listen, Em, this is the situation. I have this horrible insurance. What do you think I should do? And she said, well, you have to be very careful in this situation because MRI can be a few $1,000s. This surgical procedure could be a few $1,000s. There's prescriptions, there's follow-up, there's maybe some braces. And I said, well, that's probably not going to work, right? I'm new to the Bay Area, kind of doing the Silicon Valley dream. And if I have to go through all this costly procedures, it means I have to go back home and get a job somewhere else. So she said, well, why don't you start with the MRI? There can actually be some cost variance to that procedure. So make some calls, find out anybody you can out there that does it, and see if they'll give you some insight. So I started making phone calls. It was very difficult to find out a price from anywhere, but I found a few and worked it out with some. And the long story short is that thanks to my older sisters empowering me with new information, I was able to get through this medical episode fine and stay here today. So with that in mind, let's take a step back and look at kind of the big picture of the industry. So the US healthcare system as an industry is enormous. To give you some context, on the left we have the US advertising industry, kind of where the Facebooks and the Googles and the Snapchats play, and it's $150 billion. Compare that to what we spend in the US on healthcare, it's $2.7 trillion. And not only that, but it's a mess. Things are broken, things are inefficient, there's a lot of friction, a lot of competing incentives, so a lot of room for opportunity. As a country, we rank 46th in how efficient countries are in using this healthcare spend. So essentially, we're not getting a lot to show for all the money that we're putting in. And this is my favorite graph. If you guys take one thing away from the US healthcare system, what this is showing is citizens in nations around the world as by life expectancy on the left side. So as the dots go up, people live longer in these countries. And as it goes across, they spend more per person. And you can see we have a kind of a nice trend developing here. As countries spend more, they tend to do a little bit better. And then way out on the side, we have the United States, outspending anybody by a huge margin. And one of the largest reasons for this is that we don't make value-based decisions as patients. So kind of thinking back to my experience, I was really trying to find the most value because it was important to me as a patient. So as American consumers, we're amazing at making value-based decisions. So for your standard purchases like TVs and stereos, cars, we come up with an idea of what we want to buy. So I'm talking about this top row here. You have an idea for a need. What we do next is we explore the options and how we can satisfy that need. And then we evaluate criteria of each of those options. The most important one is price, obviously, it's universal. And then what we do is we make an intelligent decision based off our own personal, unique situation, and then we buy something. This is universal for almost all situations except for healthcare. When we're a patient in the US healthcare system, this is our decision-making process. We identify a need, a reason to purchase something. The next step is we purchase something, and then a bunch of time goes by. We get a little envelope in the mail that tells us how much that thing that we purchase actually cost, and that's usually followed by a bunch of emotion. So moving on from the decision-making process here, you can see a lot of value is obviously lost when we fail to look at options and to look at the price associated with those options. So here's a quick glimpse at sort of a unit economics of how MRIs are today. So if a patient purchases an MRI, this is the far left bar, out of network, so this is kind of like how American commercial insurance works. On average, that cost is about $1,200, and that's just the average cost. The extremes are way out there. It goes up to $4,000, $5,000, $6,000, $7,000 for the cost of one procedure, but on average, it's about $1,200. So if we can show the patient just where their in-network options are, so things that have been pre-approved by their insurance company, you drop down to $600 on average. So huge savings. Again, that's still the average. And then if the patient can make an intelligent choice for this one procedure within that smaller set, the cost drops down to $200. So that's the 25th quartile within that range. So you can see just from a simple redirection for something as simple as an MRI, you could stand to save $1,000, just like that, from the cost of the entire system. So why is this hard, right? A great question that was alluded to before. For one, the incentives are very much misaligned across the entire ecosystem. So the big players that control a lot of pools of money, they make money at different times when different things happen. So there's a great deal of friction. Data access is very, very difficult. These things have kind of, this ecosystem has grown and evolved into a very, very complicated, siloed off bits of information. And to calculate these out-of-pocket costs, you have to tie a lot of that back together. So it's very difficult. Also, doctor's time is very valuable. They don't necessarily give you the time of day unless you can really show merit with a product. So that's what we've been working on. And then finally, my little elephant at the bottom is regulation. So medical regulation in the US, you can imagine, is very difficult. There's one notable issue called HIPAA, which is just a privacy policy legislation put on by the government, which basically says you can't just build technology, you have to build HIPAA compliant technology. You can't just build a company, there has to be HIPAA compliant organizational structures within it. So that's it's led to a lot of late nights for myself. So the solution to all this that we've come up with is called Stroll. And what Stroll is it's an iPad-based application that we give to doctors, so your primary care doctor in the office, and he uses this application to show you the exact out-of-pocket cost of all of the different options that you have for an upcoming procedure. So, when I went into my doctor and they prescribed an MRI, they said, this is the next best step for you to find out what you need to do. It would have been great if I could have just seen the 23 options that I had within, 15 miles of my location, and it would know enough about me as a patient to say, this is my insurance information, this is my deductible status, this is the plan I have, here's how much I've paid in for the year, and here's the exact out-of-pocket cost if I want to choose any of these. And then I have my doctor there with me, to kind of help me through this decision, because there's more at stake. Maybe they know some of the doctors that are in there, so they can, do faster test turnaround times and just make recommendations based off that.
How are you collecting that data?
What data?
Well, if I'm Blue Cross, Anthem, whatever, and I know my deductible is $400, then what?
Yeah.
Then how do you know
How do we
that?
crunch it?
Well, how do you know that?
Yeah, so our company, the model we've built, which I think is my next slide. Oh, I got two. Here we go. So the model we've built, we spent really the last 5 months of our lives talking to hundreds of people in this whole ecosystem. So a lot of insurance companies, 200 physicians, people that are in the large hospital systems. But essentially, we needed to build a model where all of these people won at the same time. The patients, the physicians, the providers, and the payers, our big 4 Ps that we talk about. So on the far right, we have provider essentially means large hospital network. Payer means insurance company. These are the people that we are selling to. So the business model is it's an enterprise software sale. We can come to insurance companies and say, hey, listen, every time one of your patients makes a more intelligent decision, you stand to save hundreds to thousands of dollars. So there's the financial incentive. There's a lot of softer incentives to why they want to do this.
Except if I'm the patient, I'm looking and I'm saying, well, this option is $1,200 and this option is just my $20 copay. Mm-hmm. Which means that my insurance company is paying the rest.
In what sense?
Well, let's say I'm getting an MRI. Mm-hmm. One option is to go off the grid.
Yep.
And pay $1,200. Okay?
Yep.
The other option is I pay $40 and my insurance company pays the rest.
Yep. Yeah, so the way that it works.
Okay, so that shows up for me and I go, well, I'm going to pay the $40 and have them pay.
Right.
So it's not in their best interest.
No, it is though, because if we go left to right and say it was just off of the prices of it, the way that these insurance plans work, that an even increasing number of Americans are getting now today, is first you may have a copay. On top of that, you have a deductible. So the first amount of money that you as a patient are on on board to pay. And then after that, it goes into this co-insurance phase where you might pay 20%, your insurance company might pay 80. So for the first, 40, few $100s, that's all patient. And if that is more than the price of it, the insurance company doesn't pay anything. It's just the patient. And then as you get into that co-insurance phase, so as you move to the right, to higher costs, it's really just a percentage split that increases. So the insurance company pays a lot more as you move to the right, and the patient pays more, but at a smaller percentage, until you hit the max out of pocket, and at that point, the rest is all insurance. So it's actually if you can drive people to the lower negotiated price, both shares of that cost owning go down together.
But my example was not in the best interest of the insurance company.
If you go out of network?
Yeah, if I go off network, and that's $1,500.
Yes.
Or
Okay.
I go with my insurance company
Right.
instead, and they have to pay for
So in the out of network, the price usually jumps dramatically.
Yeah.
And then also there's usually there's still mechanics in place to where we share in the cost. It's not just all me as soon as I go off. It is if I pay straight cash and just negotiate with the person. Insurance companies removed from that. But if you go out of network, it's usually just a different split of the co-insurance where the patient has more built into it. But on the whole, it's still so much better for the insurance company if the patient comes in.
How do you make money?
So we make money by doing enterprise software deals with these large systems, which involves the standard model that they use is a...
So you're saying who? The hospitals?
Yeah,
or the insurance
companies
are
exactly.
going to pay you
Yes. Yep.
a
And they do.
one-time fee or an ongoing fee? Or
Yeah, so the contracts that are in use today in these kind of situations are kind of complex. So we're playing with a few models now, but in general it's per member per month. So we may say, a penny per member per month to roll this out as we start hitting enough doctors to where your members are impacted. So there's the pricing schedule, and it also kind of overlays with the impressions, so those that we hit. And then we could also do some hosting fees. There's generally upfront licensing costs to kind of implement it, but it's very much like it's a very high touch sale, high price sale, and then it usually has a fixed price as well as a per member per month.
And you think that this, what happens down the road if you've got all these guys? Is there an additional business that, because money saving businesses aren't always the best, but
yes, great question. Yeah.
So is there something else? Now you've got them all. What else can you sell them?
Yeah. So there's about 139 different ways we can go. Some that are really interesting is our initial target market as a user base is this primary care physician. So you say that first line of defense, when you're sick and you go see your doctor and he says, okay, the next best step is for you to go receive this procedure. Now there's a sea of specialists that do that, right? It's a referral to elsewhere. And right now, the Rev 1 that's kind of where it ends. But something that's really exciting is we can tap into the schedules of those specialists and say, okay, well, let's look at these options. Here are the prices. Here's where they are. Oh, here's when this one has availability, right? This one actually you couldn't get into for 2 weeks. That might impact your decision. Here you could go tomorrow. Oh, they've actually just notified our system they have a new opening, or they want to incentivize people to come at off-peak times, so they've lowered their price. And you could even get into a situation where people are feeding information back when they have less inventory, and it's almost like a Google AdWords, like a bidding to kind of incentivize patients to choose their option. So there's a lot of stuff you can do with it. And then there's feedback loops, so we can help patients understand, you've selected this option, remember to go, here's something you need to know about the procedure, reminders, text messages, follow-ups. And once you tap into schedules, it opens up a lot of new territory. And then we can even enhance the data. Right now, the doctor is the person we trust the most. They're the most important person in that decision-making process, and whatever the doctor says, that's where we come in. But as data becomes more universal, and efficacy, which is just kind of like how well a specific decision or recommendation works for that patient's own unique case, we can feed new data in to help the doctor actually make those decisions. So he's recommending this pharmaceutical, here's a dozen more that work in this space, here's the cost variance to those. We know some genomics data about the patient because we tapped into their 23andMe, so we can sort of overlay that against it, and it just spins up from there.
How long have you been at it?
So the project started in May of last year, and we quit our jobs and formed
May
a company.
2013?
Yeah, 2013, yep. And so it's been a company since October of last year, and we've almost got the product architecture completed, and we're starting to shove data into it now and having initial conversations with bigger payers and providers.
no one's paying for it yet.
No one's paying for it yet.
And how have you gotten the money to quit your job?
Yeah, we got a small seed investment. Actually, it wasn't even an investment. It was just free money from a large payer who basically said, we don't know for sure if you guys can pull this off, but if you can, this has potential to solve some of the most large problems in the entire system. So why don't you just take this, run around, and show us what you can do. So that's where we are today. And then we're kind of bootstrapping and self-funding for probably the next short to medium runway. And at that point, if we can prove the model, if we can do a deal, that can leapfrog a seed round essentially, because these are such high ticket deals. But a lot of options to just throw gas on it once we figure it out.
Great. Good. All right.
Thanks, guys.
Stroll. Oh, wait, one more question. How's your knee?
Better.
Oh, did they fix it?
Yeah, I'm in a hockey tournament again in 2 months, so I'm all good.
Okay. Terrific.
All right.